Welcome to everyone. My name is Adrian Randolph, Dean of Northwestern's Weinberg College of Arts and Sciences. Thank you so much for joining us today in this virtual conversation. This is the second in the series, and the goal is really to share with you some perspectives on the pandemic from faculty experts at Weinberg College. Before we get started, a bit of housekeeping. First, if you have any technical difficulties during this talk, please use the chat function if that's available to you. I suppose if you aren't on Zoom, that's other technical difficulties, but you'll have to deal with those separately. We will also be spending some time toward the end of our time together with Q&A. And so if you could submit your questions through the Q&A bubble on the bottom of the Zoom window, it should be to the right. It says Q&A and it has a little cartoon sort of voice bubble above it. That's where you can put questions, and we'll get to those at about 12:45. And so finally, before we begin, thank you to all of you, our alumni and leadership donors, supporters, who really help Weinberg College faculty and students succeed in what we try to do. So thank you for all your support. So now let me turn to the topic at hand. We are, of course, undergoing not only a truly shattering health crisis, but also what appears to be a tipping point in our country's struggles with racism, power, and injustice. And today we want to reflect, while in the midst of these upheavals, on the intersection of health, inequality, and the ways in which cultures respond to disease in ways that are profoundly influenced by politics. And to help us better understand these issues, we're joined today by Dr. Adia Benton, Associate Professor of Anthropology and African Studies, and she's also affiliated with the college's Science and Human Culture program. She's the author of the award-winning book, HIV Exceptionalism, Development Through Disease in Sierra Leone, which I read a couple of years ago with great interest. It's a brilliant book. And she's now writing another book on the Ebola outbreak, the recent one. I don't know the exact date, she can tell us, in West Africa, but I know we all remember reading about. And so she really is an expert on these types of epidemics, pandemics, and the cultural and political sort of worlds around them. So she's very well placed to help us think through what's happening now in this country and around the world when it comes to the COVID-19 crisis. So Adia, thank you so much for joining us.
Thanks, Adrian. I'm happy to be here to chat with you and our alumni and the college supporters.
So we're going to kick this off with a very broad question. Given your work on, let's call it the modern plague, which is the name of a class you were offering this past quarter, a first-year seminar, I'm interested in your reflections on COVID-19 and our nation and other nations' reactions to it. Has anything happened which has surprised you, sort of said, wow, I didn't expect that? Or given your work, have things unfolded pretty much in a way that you could have predicted given your knowledge of other such sort of pandemics, epidemics, etc.?
So there are a few things that strike me as surprising. And the first is actually how weak our government response has been. But I'll circle back around to that one after I talk about what hasn't surprised me. So the first is that because this is a new disease, we're learning a whole lot about it in a fairly short amount of time, which means a lot of the messages about how to prevent it have changed. So I don't know if anyone remembers this, even this week, the World Health Organization came out with a statement about how, first of all, how you should be using a mask, which, this is a big surprise to some of us, right? We've been dealing with this for the past month or so, where we have sort of taken that as a really good way to prevent the disease. So there's that. But then the other thing that they came out with was the fact that asymptomatic carriers are not transmitting the disease, and they had to walk that back. They had to walk that back because what we actually don't know is how many people are actually asymptomatic ever carrying this disease. We know that lots of people can transmit during their pre-symptomatic phase. That's very technical, but all I'm saying is we're still learning a whole lot. We know how it's transmitted. We know that it's a droplet infection, which means that we need to kind of worry about the stuff coming out of our mouths and things like that. We know that people can become very ill, and even if we're not concerned about death. We know that people as concerned about, well, I'll just put it this way. We should be concerned about the long-term effects of this disease. So in other words, I guess to get back to the bigger question, yes, it's similar to something like HIV, where in those early days, we were learning a lot about how it's transmitted, but we've been working at much rapid speed. The World Health Organization, the CDC, have not been as great as they normally should be or they could be. We have also seen some really good successes. So in New Zealand, I'm sure some of you have heard that they haven't had any new cases in a few days. It looks like they've actually resolved their crisis. So we have South Korea as people to learn from. We have Taiwan as a group to learn from. We have Japan and China, so on. So I'll just say that.
So I'm interested, given your research, sort of in your background, how does COVID-19 compare to the nature of the Ebola and HIV outbreaks that you've studied? As well as how have we handled this one differently or similarly, perhaps? And maybe along the way, you mentioned the WHO and the sort of the missteps this week, certainly about the asymptomatic folks being not passing on the diseases much as thought, that they had to walk that back pretty quickly. But what do you think about the WHO in the context of West Africa? And to give us some perspective on, the announcement that we're no longer going to be as a nation supporting it, I'm just curious, I'm sure some of our viewers would be interested to know how an expert thinks about the WHO. Is it a force for good? Is it a force for bad? Is it got problems? I'm sure it's a complex answer, but that would be interesting to us, I think.
Yeah, so, I've been thinking about this a lot. Not just, so I guess one way to start thinking about this is, one of the things that I've studied with respect to HIV, but also with respect to Ebola, is how communities are expected to respond. So how do they both interact with the government? How do they interact with scientific communities? And how do they embrace or otherwise reject the kinds of messages being communicated to them about how to protect themselves, how to protect each other? And so that's kind of like the big picture question for me with Ebola and HIV. So I live in the south side of Chicago, and I've been struck by, even though I'm living in a place that actually is high prevalence for COVID, I've been struck by how little interaction I've had with my city about how to protect myself, how to ensure that my neighbors understand how to protect each other, how should we interact with each other. How do we learn about the disease, but also how do we learn how to get tested? How do we get contact traced? I'm sure you've all heard all of these terms. So if I had to talk about that, that's sort of like the angle that I'm coming from, but I also study the institutional effects. And so which institutions would be responsible for that? We live in cities or towns which have health department states, and then we have the CDC, which is our sort of national agency that brings assistance to the centers, to all of the different health departments. And that's what happened during the Ebola outbreak in West Africa, which was 2014 to 2016. They sent one of their largest deployments ever to West Africa to help the ministries of health and the local community organizations really communicate messages to the public, to make sure that that the messages got out there, to make sure that people were adequately and safely moved to health facilities and treated well through the course of their illness. We are still struggling with that in the United States. It's better in certain regions that had earlier experiences with the outbreak. When it comes to the World Health Organization, it's a technical agency. It has been underfunded, and I think it's been underfunded for many years and undermined by different governments' agendas, powerful governments. The U.S. is its largest donor. Gates Foundation is also a top donor, and China sort of stepping in to fill in the breach. But basically, all the member nations pay into it. So when we stepped out of the World Health Organization, we're reducing the funding of an already starved institution. But we're also, I think, having to having to think about what that relationship should be, which is how does it perform its technical advisory role? One of the things that we're constantly struggling with is it receives all of its information from countries and then makes a sort of big picture determination. When China or the United States or any of these other countries don't fully buy into that, the world suffers. Because they're supposed to be able to help and offer technical assistance, technical advice, provide really good guidelines for how we should behave, how we should be handling these outbreaks. They're not the only agency, but they're sort of a clearinghouse agency. Uh-huh. And so that's one of the things that I worry about when we say we're not going to be invested in it anymore. They're kind of our global alert system. Which, I want to say one final thing, though, about this communication question. They have a very small communications office, and it's been bothering me because we keep getting these really bad messages or not well-formulated communications about whether masks work, when we're transmitting, all of these things. And so I feel like this is an opportunity, actually, to properly invest in the institution, so that they can actually do the kind of technical guidance that they're supposed to be doing.
Got it. Thank you. I think that's helpful. So as you know, in the US, COVID-19 is disproportionately affecting Black and Brown communities in the country. I'm curious what your thoughts are about this. And is there anything that can be done to help improve that situation?
Again, speaking from the South Side, one of the things that I think is a challenge. So one of the ways that public health people talk about this is that many of the conditions that make people susceptible or vulnerable to COVID-19 are also linked to race or racism. So a lot of this deals with, I'd say, unsafe, perhaps unhealthy food, neighborhoods, environments, and so on, and is in addition to what people call pre-existing conditions. Mm-hmm. So all of these have often been linked to other kinds of racial differences and disparities. And so these are predisposing people to COVID-19. Some of that is employment linked, or it's an occupational hazard. So as many of you know, we had this category of essential work when we were everyone was told to stay home and to kind of do this extreme social distancing experiment, which, by the way, the countries that had the most success with COVID-19 didn't really go there, in the sense that what they did was they actually ramped up testing, they ramped up contact tracing, and they made sure that hospitals worked at the capacity that they're capable of working at. So that's what actually happened. And so what we're actually facing right now is we have two things going on. We have these racial disparities that preceded the epidemic, and a system that isn't set up to adequately address either those disparities or what is actually needed when it comes to addressing this disease. So that's the first thing. I think I read something yesterday that said that one of the disparities explaining sort of the essential work exposure question is that only 1/5 of Black Americans were able to stay at home during this outbreak. So these are people who most of these people had to go to work. So we're talking about frontline workers, so healthcare, childcare. We're talking about bus drivers, everyone who runs their transportation, people who do sort of service work. Those are the people who actually were not protected. And so that helps to explain some of this. We saw very high numbers of COVID-19 at NYPD. We're probably going to see them with the Chicago Police Department as well. And so these are people who are interacting with communities of color also at higher rates. And so this is kind of why we're seeing these disparities. So there's the health stuff that is linked to racism and other kinds of racial disparities, then there's this sort of interesting occupational hazard that maps on to racial difference and racial divisions.
I think it's interesting you raise the issue of, the interaction between police and the prevalence of certain groups in the police force, etc., given the context of the protests we're facing in the wake of George Floyd, Breonna Taylor, Ahmaud Arbery, and others. There's been this sort of uptick in protests, and I'm curious, especially given your experience in West Africa, looking at the interface between disease and politics and the effects of politics. What are your thoughts about the connection between the wave of protests and the pandemic? I mean, do you see anything which is, of course, I think most of us around this virtual table are familiar with what's going on. Do you see any resonance with what you saw happening in West Africa, or is this situation really particular to the United States right now?
That's, I was thinking about this question last night. About 5 or 6 years ago, I guess it was 6 years ago, 2014, right? I co-authored a piece about Black Lives Matter. And so what was going on in Ferguson and what was going on in Liberia, they sort of overlapped. It was interesting to look at pictures from Monrovia, where the police and military had encircled this one slum community. It has 60, 70,000 people. It had been slated for clearance for years. And they were basically kind of trapping people so that they could sort of keep people who have Ebola in place. Mm-hmm. And they were importing people and bringing people in, and basically people rebelled. They were like, we can't live our lives. We can't go about our work, which was fishing, selling, and trading in Monrovia, and we're being hyper militarized. And so they resisted. It ultimately ended with a clash between residents and the police, a militarized police force, militarized by the U.S. government, in fact. And so one of the things that I wrote about was how Black Lives Mattering was very much linked to police violence and social control, linked to, a series of pathogens or pathologies that the state was trying to address. So I think one of the things that I'm concerned about is, many of the conditions that sort of led to COVID disproportionately affecting Black and Brown people are also the conditions that expose people to hyper-policing and violence from the state. So there is that piece. And so these protests kind of turn this around in an interesting way. One of the things that I am concerned about, and a lot of people have sort of talked about this, is these protests pose a challenge in the sense that people think it's so important that they're willing to risk their lives, but people are also caring for themselves and each other by putting on masks and distancing and things like that. So we're all worried about the escalation or the potential that there will be greater transmission as a result of these protests. But what I would say is the response to the protest is also shaping transmission dynamics. So again, to use Chicago as an example, when the mayor set a curfew, an arbitrary curfew while everyone was out, arrested something like 1,000 people that first night, they're ultimately creating a condition for people who are crowded in as they're being carried away to transmit the disease. Jails are absolutely one of the risk factors or sites of risk for transmission. So that's another opportunity, but we're also talking about a lot of the police are not wearing protective gear. And because they interact and interface with communities all the time, they're putting themselves at risk, and they're putting the people that they are detaining and protecting at risk. And so to some extent, like the ecology of the protests lead to this thing, but they're also kind of exacerbated by the conditions that people are trying to put under control. And so we're kind of seeing that back and forth.
I'm going to make a comment here, which is sort of off in a different direction. As some of you may know, we have Adrian Moore, who's going to be our guest speaker at our sort of virtual convocation this year. And we were discussing how the intersection of issues of masking and breathing are really interesting. And this is just a comment about the crisis from someone who's an artist. And she was saying how she was struck by people wearing masks and trying to control breath. Of course, the issue of I can't breathe and breathing when it comes to constraining people and sort of violence. But then also pepper spray and this sort of notion of what it is to control one's body in terms of illness with coronavirus, which is of course a pulmonary respiratory problem. It just happens to be coincidence in some ways, but these things are coming together. I think artists are thinking about, what are these symbols of breathing and masking? Because of course masks were also a part of protest, certainly economic protest before this. And so there's a tradition of masking one's face at protest. It's just an interesting confluence of things that are going on. And then when I was thinking of your work, I don't know if this is true, but when I think of Ebola, I think of people fully in sort of hazmat-like suits and breathing sort of non-contaminated air. And it's funny how the very air we breathe and breathing becomes sort of a topic for conversation and thinking about one's body in relation to this crisis.
Oh, no, that's actually really brilliant. There's actually a collection at the Block of photographs by, I think he's a Malian photographer who actually, he was hired to do Ebola photos, but then he did these sort of portraits and tableaus as well that were kind of, where everyone's wearing these sort of hyper, they look like African masks, but they look like PPE as well. And so and there's a really, I think they'll be up next year if people are interested in seeing that. But yeah, so I think about that a lot too. I actually also, a few years back, edited an issue of a journal where one of the authors wrote about the Gezi protests in Turkey and talked about how it was basically about medics who were actually seen as enemies of the state because they were protecting protesters who had been exposed to tear gas. And so he talks about what I think he calls it atmospheric violence or something, where this idea is like you're no longer being beaten or attacked. They're just sort of doing this sort of blanket suppression by changing your ability to breathe, by basically, and then so this tactic is a fairly, it's widespread, but it's also part of this sort of older tradition of counterinsurgency, sort of trying to manage this violence in the streets. So. And
again, I'm going to riff. I mean, it's interesting because another conversation, we haven't had a formal recorded conversation. We have faculty members working on levels of particulates in different neighborhoods based on how much diesel fuel is used and different types of fuel, which again feeds into the narrative you were talking about, that there are some neighborhoods in cities that are more dangerous or there's more risk of asthma, et cetera, based on the atmosphere. And I think maybe, I hate, part of my job is to look for silver linings in clouds. And one of the hopes is coming out of these dual crises that there may be a sort of attention to certain neighborhoods and the intersection of economic and health issues. And I think there's a lot of faculty, certainly through IPR, and I think some of your colleagues in anthropology as well as in chemistry working on these sort of dual issues. So to bring it back to campus, I'm in a situation where we're thinking daily. I was just in another meeting this morning about how do we safely open up a space like the Evanston campus, and certainly the Chicago, but I'm more involved on the Evanston campus. I'm thinking you as a professor, as a person who's thinking about these things, how, do you have any advice for me as we try to reopen the college and the university to our community, how we communicate what safety means during a pandemic?
Wow. I know it's one of those things. I mean, I think we have to think about, and this is again, one of the lessons that I think definitely emerged from my work in Ebola, but also in HIV, which is starting with the community. So who are the members of the community and who are the most vulnerable people, and how do you protect that group? And so, the way that I've been thinking about it is like, the campus, at least the Evanston campus, is sort of like, it's a semi-permeable bubble in the sense that certainly many students are residents of campus. They do everything on campus. They eat, they whatever. And so to some extent, that's sort of like an ideal situation for trying to say, okay, we're safe. We can test people. We can test people if someone gets sick. They can then be sort of isolated in a dorm, blah, blah, blah. But you also have to think about all of the people who sort of move in and out of that permeable membrane. So who are the people who will have exposures as they traverse the city or to get, and so those are the things that I think about, which is the sort of like, what are the sort of layers of risk, and how do you reduce harm or the potential for harm for the community, given how easily it's spread, but also in thinking about the ways people encounter each other. So, of course, that means we're talking about faculty and staff, people who are not. And so how do you make sure that those people are both able to protect themselves, but also are constantly, also aware of the risk that students and we pose to each other as members of different kinds of bubbles.
We've had a lot of discussion about public transportation, right? Because you can produce your bubble, but then if people are passing through high danger zones, how do you then address that? Mm-hmm. We have a couple of questions. One just came in from Paul Larson saying, and I'm just going to read it out. The WHO walkback was made necessary by the media taking an answer to a specific question out of context. How can we protect those experts who have great information from those who use their specific answers to support a particular narrative? Well, if you can answer that, Paul, I think we'll all be happier. But you can take a swipe at that one. Is there any way to control how information from experts is sort of deployed in a political sphere?
That's it's something it's obviously something I think about a lot. But even for those of us who are able to parse the information, there are a lot of us who are like, oh, the World Health Organization made this announcement, and we all kind of got really deep into the weeds, and we were like, oh, it actually isn't that people are safe. So, because a lot of us want to see our families again, like we want to see grandma and grandpa and so on. So I think actually it does start at the institution or it starts with the expert and how one frames and talks about this message. But also there are all these other channels. That's the other challenge we have. We have a social media environment or media landscape that is actively churning out and actively disseminating information before it's even had a chance to digest. And so we're talking not just about the World Health Organization's information, but the preprints that have come out that haven't been vetted. And so, I think the problem is that we haven't had one sort of trustworthy source, or we've had limited information from trustworthy sources. And that creates the sort of chaotic environment where we're sort of like drawn to a bunch of different messages that are being used and deployed for certain kinds of political ends. I think about this a lot because I consider myself to be very good at processing lots of information about diseases in the moment because I've had to do it multiple times. And I'm even having trouble not necessarily knowing what's fact, but knowing which things are worth building a decision-making process around. So in other words, from the beginning, I would say, oh, maybe I do need to wear a mask here. Maybe I do need to sanitize here. Now I'm all of these large level things that are being communicated, I've been having to translate them into risk communication for my parents, me, not my spouse, he's a surgeon who deals with people all the time. So whatever he's doing is dangerous. But I know it's sad. I haven't seen him in a while. So anyway, all of this to say, we're in this sort of chaotic media landscape. It would be useful if we had one trustworthy, and so that would have been the CDC. We get a little bit of that from Tony Fauci, but he's also hamstrung. So if we had that, somebody who sort of translates for us what our actions we can take are, I think that would be something that would work out. I don't know how you don't spin all of this information. Like, yeah, I was going to talk about China, but I got it.
Well, we have another question that might lead you there. So
probably.
Go ahead. Sorry, I interrupted.
Oh, no, I'm waiting for the China question.
So this question is, you are struck by how little interaction you're having with your government as someone living on the south side of Chicago. What kind of interactions would you expect to have, or have you seen with Ebola or HIV?
Okay, so those are two separate questions, and I can answer both, but they're related, and I love it. So the first thing is, I got 3 or 4 messages in 2 days about curfew, and when the bridges were closing, and what else? And so that would have been an interesting, I mean, I would have been happy to have received a text message or an emergency alert. Today, I don't even think I got one for the close when everything was closed down. So it would have been nice to have received an emergency alert that said, everything from this point is going to be closed. We expect this to be, so and so many days. Here are things that you can do to protect yourself. For Ebola, one of the things that actually started before, so the government had some problem with communications as well, in Sierra Leone at least. They were talking about bushmeat and things like that. But eventually what happened was community-based organizations were doing sort of door-to-door, hey, knock on the door, looking at people who might have heightened risk and saying, here's some things, here's some bleach, here's some plastic gloves. If you have any of these symptoms, please call this number and send the person away, or isolate that person until the ambulance comes, and make sure that so there were actual people going house to house, door to door, telling members of their community. So these had to be neighborhood based, so that people would not only trust information, but also feel like there's a person who they could go to if they had trouble doing something. Not to say that it always worked perfectly, but that's a typical bread and butter health education strategy. Then there were radio messages. There were posters everywhere you went. There were hand washing stations everywhere you went, and so on and so forth. So there's an actual dedicated effort to get information down into communities and to give them actionable things that they could do. So in the event of this, do this. It of course meant setting up systems as well. And that's what was supposed to happen over the past 3 or 4 months, where a lot of us were sitting at home if we had the ability to do so. And so that's what I would say. So those two, that's what I think is sort of the thing, is actually, and we're seeing more of it now. So with the contact tracers and with some of the health educators and things like that. But it definitely took a much longer than I would have expected, given the knowledge that we have about health education and outbreaks and things like that.
So these questions are lining up perfectly. I think this may connect to what you're saying. James Klatsky's asking, what might be the best manner to generate deep granular data so as to fully understand the broader and general statistics which currently exist? With those statistics, management of the highly contagious nature of the virus might be more effective. Do you have any thoughts? I know I don't believe you're necessarily a statistician, but do you have any sense about, are there things we could do to improve the collection of data? And is there some better way we could do it? And I assume one issue we face is we're not quite a centralized country the way some of the other countries you work on are. Yeah,
we struggle with the federal state distinction. We struggle with federalism. But that said, I actually do study data, the culture of data collection. So here we go. Deep dive, no. It's a part of, it was the job that I had before I started anthropology, actually. So it's been, how do you collect data? It's also why I'm very skeptical of a lot of the data that I see, and also some of the interpretations. If I were queen in this federalist system, one of the ways that I would see, it depends on what you actually feel like you need. But if we were talking about real, true community-led or community-based initiatives, I would say that would be the place to start. And I've even been asking it. So I've been in conversation with people who work for the city and people who work at the University of Chicago in doing outreach. And so one of the questions that I've been asking is, how do you begin to engage with people in such a way that they envision that they're a part of a community and that this is something that is happening at that level? And so, I would love to say you do house to house and you kind of get a sense of what people are doing and all that stuff, but I would suspect that it's easier to do it from the facility level. Ooh, scratch that. I'll tell you what happened 3 months ago when my children were about to be sent home from school indefinitely. I said, isn't it interesting that the school is the one place in Chicago that we know every child technically should be going? It's where a lot of social services are delivered. If 3 months ago we had said, let's screen every child, let's ask every single child in the Chicago, or a sample of the children or whatever, and say, has anyone in your household had the following symptoms? And then for all of those students who said yes, we kind of do this thing where we do testing. If we had the test, that's another issue. And then we start from the schools, because often we're talking, even though Chicago's schools are a mess of different governance structures, we know that neighborhood schools will generally map onto neighborhood dynamics, politics. So you starting there would have been one of the ways that could have been done. And it wouldn't have just been about data, but it would have been about shaping interventions that would actually allow for heading off big clusters of disease in those communities. Uh-huh. Because that's essentially what happened with the first cases, right? The first cases, everyone was like, oh, these people went to China and then their kids got it and there was a school in the north side and so on. And they kind of like tamped it down by doing all of the appropriate things. But we had community spread. So all of this to say is, you have to start, if you can't start from the neighborhood, you have to start from the institutions that most people pass through. Uh-huh. And you kind of have to build off of you have to build off of cases, or you have to build off of some other thing that unites people to be able to collect those data and to get that granularity. The question then becomes, what do you want to know? And to what end are you trying to put that? Because, we're still dealing with a lot of the people that we're talking about in the sort of hardest hit areas now also have a history, or at least a collective memory about experimentation, data collection, surveillance, and so on. So we kind of have to take those two kinds of issues together. Uh-huh.
So looking back now at your work on HIV, AIDS, and now your present work on Ebola, do you think coming out of those crises, as the countries you work on have, was there any, and again, this is my silver lining sort of personality, was there anything the countries you work on in West Africa, you're like, well, this actually led to some structural change that was positive? And I'm sure there were many negative. Let's not these are terrible, traumatic, awful occurrences. But was there anything in terms of the shift in communication, in public health, et cetera, that you saw happen? And are there any lessons for us to be thinking about as we look 6 months forward, a year forward, et cetera, that we should be thinking about and thinking, oh, we could improve this? And you've pointed to some, but I wonder if you could sort of sum it up a little bit.
Yeah, so again, something I've been thinking about a lot. So in my first book, I kind of talked about people who are HIV positive and ultimately how they built these networks of solidarity amongst positive people that, could have been pathological or whatever, because it's a way of hoarding resources. What I saw with Ebola survivors who actually experienced longer-term health conditions that hadn't been anticipated because of the lack of clinical study. And what was interesting about the Sierra Leonean case, I'm not sure about Liberia or Guinea, is a lot of these survivors, because of those health conditions, started to mobilize not around just more help for survivors, which they did get, they also mobilized around around the issue of expanding healthcare access, which was already sort of starting under a previous administration, but I think it could gain better traction because of this particular group of people and the resources that they were able to mobilize to bring that. So that's one thing, which is that survivorship actually led to a collective consciousness about changing, I guess, political will to expand health care. I think to some extent it also helped build emergency services, which were severely lacking in Sierra Leone before the outbreak. So they were, because they had to have ambulances and an emergency operations center and all that stuff, it actually created a new sort of infrastructure for dealing with emergencies. Now, what can that mean here? Well, what we have now is we have tested the system and its limits to some extent. So is this going to be a moment where we seriously consider healthcare for all, or at least a very basic, highly accessible health system, or a health system at all, because we don't really have one that is coherent? Is it going to allow for better investments in public health? So in Illinois, oddly, the new budget that Pritzker drew up has more public health money in it than it did before. What is going on? The Illinois Department of Health is basically subcontracting, farming out all of its functions. Maybe this is a time to bring some in-house expertise so that we aren't caught unawares. And I believe that this is going to happen, or may happen, at county, city, and state levels in other parts of the country. So I do think that there is the possibility, this is sort of prepping people, or priming the political ground for reimagining public health and its funding, because I think that's actually been one of the reasons we don't see really good health education. It's one of the reasons we didn't see contact tracing kicking up. It's one of the reasons we didn't see testing. So now we kind of have that justification rationale. So it's that piece. And then how do we think about health financing and the organization of rural health, urban health, and a healthcare system that serves the people? Now that we're starting to see those disparities play out, and we will certainly see rural upticks. We will certainly, and those are the places that have been devastated by healthcare cuts. So, these are places for mobilization. This is fertile ground for change.
That was terrific. The only problem was it wasn't in the form of a question. As a former participant on Jeopardy, as I learned just before this interview, I'm disappointed you didn't give us that. But no, thank you, Adia. That was terrific. We're so excited to hear from you. It was really informative. And I look forward to our next conversation.
Oh, thanks, Adrian. It's great.
So to all of you who tuned in, we hope you found this to be a valuable way to spend 3/4 of an hour. And as I said before, this was our second virtual conversation, and we plan to do more. So I hope you join us again. If you want to stay up to date, please visit our website at pandemic.weinberg.northwestern.edu. And we'll also be sending around that web address to you all via email. So please feel free to share feedback with us about how you enjoyed this or what you think we can improve. And with that, thank you and best wishes. I hope you're all in good health and safe from all your friends at Weinberg College and Northwestern University.